Some women may elect to have a vaginal repair, understanding that if she has another vaginal delivery, that may impact the durability of the repair, and she may or may not be okay with that. Or if she says, yeah, okay, I did have these two babies vaginally, but the next one I'm going to have a C-section, then of course, then that makes no difference. Let's go ahead and get you repaired. You're going to have your next one through C-section anyway, because that's what you choose to do, and that's fine. If she had her first babies by C-section and she's definitely going to have a repeat C-section, then of course there's no limitation. Yeah, if you're interested in surgery, that can be done vaginally.
Friends,
yes,
thank you for joining us on our show. I have a special treat for you. I have my friend, Dr. Folusho Tugbiyele. I am working on my pronunciation, and I just found out his middle name is Stephen, and we were just talking about how I have so many family members called Stephen, so that's like a name that's near and dear to my heart. So he's like my brother already, just by the fact that he has that name. I'm like, you are a family member. You are welcome to family events.
yes, this is good.
Yes. And the question I wanted to ask you, your nickname is Dr. Foley. So
Yeah,
tell us, how did we come up with this nickname of Dr. Foley when you have so many other names?
it's
I'm
so
very,
it's
very curious.
I'm telling you, I'm saying I have to. How do I streamline this? My names, but so Folusho, me actually in Yoruba, Nigerian, it means to be put in God's care. I was born prematurely, 7.5 months with my mom, like 29, 30 weeks. So I was a preemie, and so that means to be put in God's care. And so growing up in Nigeria, because I did spend a part of my childhood in Nigeria, Foley was a nickname to Folusho. Don't that's so parents, friends, close friends, my siblings called me Foley growing up. And then of course I then go into female urology, urogynecology, only to find out like there's a Foley catheter. So it kind of is a weird connection there, or unique connection I should say. But that's where Foley came from. It's more of a, so people who I grew up with know me as Foley, but professionally in professional circles, my Stephen's my middle name. People, if they stumble on Folusho, which is Nigerian. So depending on who calls me what, that kind of determines which circle. If it's at work, usually Stephen. If it's family, friends, Foley, and if it's somebody from Nigeria, uncle, they'll call me Folusho by my first name. So
Awesome.
that's the story there.
I love it. I love it. I love it. And talk about, like, we're both Christians, so
Yes,
I could speak in the kind of different terms, but I like, as Christians, we believe that, God plans our lives out and our steps are
absolutely.
ordered. So it's
Yeah.
like, this was like a little like hint. This is the direction you're meant to go. And so I really believe like that was apropos. It was like the path
Yeah.
we're supposed to go on. So tell us,
Yeah. Yeah.
going through medical school, okay, do I even dare start? How did you
Oh,
decide to
yeah.
become a doctor? And how did
Yes.
you decide to focus on urogynecology? Because this is a very unique field. There's not a lot of you guys. How did you navigate this path and, decide? Of course, it was already predetermined, but what was your thought process?
Yeah. So, I mean, again, growing up in Nigeria with my parents, my dad was a pharmacist, and the way it works in African, in Nigeria, me seeing him growing up is, patients, unlike the United States where patients would go to a doctor, and if you need medication, you get the prescription from the doctor, then you go to the pharmacist to have it fill out. In Nigeria, that doesn't work like that all the time. Oftentimes, if there's an ailment, rather than going to the doctor only to get a prescription, a lot of people would just go to the pharmacist. And so there are times when the pharmacist actually acts like, oh, okay, this is the condition you have and this is the medication that can fix it. And I saw that so many times growing up, didn't think twice about it because you're a kid. And so I think just the exposure to the healthcare field and the caring for people and taking care of people, I saw that through my dad. I just didn't want to become a pharmacist and just deal with medication. I want to take care of people and, hands-on. So that's where my first initial exposure to healthcare came from. And then going through school, I did gravitate more to the sciences, biology, physiology. Yeah. So, and then I applied to med school. And then I thought, when it was time to decide what field to go into, delivering babies and helping, being a part of that special moment of family was the best thing in the world, So I pursued obstetrics and gynecology at New York University School of Medicine. And then I became a resident. And, when you're a med student, you get one picture of things. And when you become a resident, you see it's a different picture. I'm like, because when it's time to rest, oh, yeah, the med student, you can go sleep and you can go rest. When you become a resident, you're up. So like, ooh, okay, this is different. I do like to work hard, but I like to work hard during the day and like to sleep well during the night. Rather than I decided to focus and specialize in the surgical aspects of our subspecialty, not just because of the quality of life, which is important, but I had mentors who really reinforced my surgical skills and hand-eye coordination and skill sets. And so I felt like there was a gifting there. Of course, God put that there. So I just had to pursue that since I was good at that and I could serve women that way. And so now, as a urogynecologist, I take care of women who have pelvic floor issues, things that happen when women have children, live life long enough, menopause, perimenopause, bladder leakage, prolapse, bladders, and things of that nature affects many, many women, not easy to talk about. But I like to be a champion for women and say you don't have to live or put up with it. There are good options and solutions to improve your quality of life and improve your comfort, control. And so I like to make sure that women know that they don't have to live or put up with it. So that's I went to urogynecology. That kind of combines all my interests and skill sets, and I enjoy serving women that way. I've done it for the last 21 years, and it's awesome.
Ah, yes. Thank you for taking us along on your journey. And with regards to female pelvic health and pelvic prolapse, it's so common.
Yeah, yeah.
I think, especially as women, first of all, have children, it's not uncommon to have some challenges after having children. So, say for example, there's a woman who's, had a child or had like multiple children, during the first birth, and they're having some challenges and they're not sure where to go next. What would be the first steps? Or should they, perhaps talk to their family doctor first? Should they talk to their OBGYN? Are they able to reach out to you directly or like a urogynecologist directly? What would you suggest the first person maybe to
Person,
approach?
sure,
And
yeah.
then maybe the other question when I ask, what are the treatments? Because there's it sounds like there's definitely a wide range of treatments. Maybe I'll hand the mic over to you in terms of where to start.
Sure. Yeah. So I think that one of the best places for a woman to start is with her OBGYN. I mean, so the person, the very person who delivered you can counsel you on what things to do. And it's very, I think it's very important for women in the postpartum period. You're home with that baby. Yeah. Not obviously the next day after you have a baby, but within those few weeks after having a baby, part of that body recovery, one of the conversations that needs to happen, that should happen, is how do we strengthen and rehabilitate the pelvic floor? That's oftentimes not focused on. Why? Because there's a baby, there's the nutritional components of a baby, mom's recovering, sleep. And so there's so many aspects. But I think also a key aspect of the postpartum period should be a woman's pelvic floor health. And so, yes, that's a natural conversation that a woman can have with either her obstetrician gynecologist or her family doctor, depending on who is caring for her during that time. What can be done to begin to focus on that and to begin to pay attention to that. And usually, within the first year of life of a child, is a woman's body is recovering from this birthing process. And so that needs to be part of that process. Kegel exercises, how to do them correctly, in what manner and how often, and those kinds of things. And during that period of time, some women can benefit from pelvic floor physical therapy if they find challenges doing Kegels on their own. In a lot of circles, a lot of women, a lot of people are even beginning to think that that should be a standard aspect of the postpartum period, to see a pelvic floor physical therapist. And so to help women, coach women on how to do those exercises most effectively. And so I think that would be key for women to begin to do. They don't have to see a urogynecologist, although there are some women, depending on their insurance, if they are using insurance, that see me first and I tell them the very same thing. But that conversation naturally should happen with the person your gynecologist or your obstetrician who delivered your baby.
Ah, okay, that's great. So definitely the first place to start is, pelvic floor physiotherapy. So, say for example, a woman has been doing pelvic floor physiotherapy for about 3 or 4 months, or
Right.
even like 5 or 6 months, and things are not really improving. There's some issues with leaking, things are just not the same. What would be the next steps that you suggest? Should they just continue with physiotherapy? Like, is there a timeline when they would say, I need
Hmm.
a little bit more intensive? What are your thoughts?
Yeah. So, there's definitely evidence that it takes at least 3 months of consistent pelvic floor muscle strengthening before reaching some sort of a maximum benefit. So, before 3 months, can't really say that this is either working or not working completely yet. And that's consistently for 3 months. And, there might even be in some scientific circles 6 months. So, I would say 3 to 6 months. But during that time, a woman is recovering from having delivered her child. And I think that's still a reasonable time to give women, between 3 to 6 months of consistent pelvic floor muscle strengthening and bladder retraining. If after 6 months there's no change, then I would say, okay, that would be the point where seeking a specialist is helpful.
Ah, okay, that's great. That is great. And so a lot of people or women, especially if they've already had, maybe a traumatic experience after giving birth, maybe they had a natural birth, maybe they had a C-section, but we'll talk about C-sections later on. That's another
Yeah,
interesting related topic. But so say, okay, they already had a quite a traumatic birth experience. They're like, I'm not sure I really want to go through more procedures. Why am I going to go see a urogyne? From what I understand, these are surgeons.
right.
What
I
would
understand.
you say to this individual, or what else do you think can be done, perhaps before going into surgery?
That's a very good point you bring up because you're right. A lot of women will think, oh, kind of like the same adage: if you go to a barber shop, you're going to get a haircut, right? Yeah. So people believe that if they see a urogynecologist, we're going to gear towards surgery. And what I would say is, for my practice, I lay all the options out on the table. I tell women, I'm not a woman, but I do understand. Yeah, I think yes, I've done all the training, fellowship training, and all the years. But I've been married for 22 years and I have two grown daughters. So I'm surrounded by women. I've been taking care of women for 20 years. So I've cared for thousands of women. And for me, my main goal is to make sure a woman understands what's going on and understands her options. So I lay all the options out on the table, whether it's behavioral modification, dietary modification, lifestyle changes, right? And those things can be helpful, especially in women who have like an overactive bladder, gotta go, and she can't make it to the bathroom on time and she leaks if she doesn't. There are things that can be done. What are we drinking? How much are we drinking? How often? How late are we? All the things. How's your other medical conditions? How does that impact, your bladder control? So those are things that are very important to me. And then we talk about non-surgical options, which we can get into more detail of. There's pessary devices that can be fit in the office. There's pelvic floor physical therapy. My wife's a physical therapist, and not pelvic floor. So I do get it that some women, a lot of women, I should say, prefer non-surgical options, and that's reasonable. However, it's also important for women to know that the non-surgical options are not helpful enough, that you don't have to live or put up with it. Because that's what I see. Women say they've been living for years and suffering for years. They're in tears in my office. And that's what's like, oh gosh, no. You've tried. It's not your fault. You didn't do anything wrong. You had a baby. But you're not, Kegels work for some women and they don't work for all women. And there are options. You don't have to live or put up with it. And after a woman has surgery successfully, her life's back, her confidence back, she's more comfortable, more confident. She says, oh, I wish I had done this years ago. So those are the women that we don't want to miss, right? Those women who want to have surgery need to, they've tried non-surgical options, and don't want to put up with or suffer unnecessarily. So,
Okay, awesome. And you touched on so many important and interesting things. You talked about lifestyle modifications. You talked about, adjusting how much you're drinking, when you're drinking. And as another physician, you talked about other medical conditions. So, what other medical conditions should be optimized or controlled in addition to perhaps exploring surgery? What else should people be aware
sure.
of? Even your other
Yeah.
physician colleagues who are, may or may not be managing these other medical conditions. What should we be thinking about optimizing?
Yeah, so I would think like heart conditions, hypertension, vascular conditions, peripheral vascular conditions that affect how blood is distributed in the body. And there are some women who have venous congestion, severe varicose veins, and during the day, the extra fluid that they are carrying pools in their legs, and then at night, when they're finally ready to go to sleep and they're lying flat, and the heart can now work optimally, not work against gravity like when a woman's standing, but finally she's lying flat, then all that extra fluid perhaps that's been accumulated right in the lower extremities then have to find its way out of the body. And then that's where women find that they have to get up several times at night to go to the bathroom. And so that's where we can talk about, well, let's make sure we're not overdoing with fluids. Let's make, maybe it's compression stockings during the day, maybe taking and maybe elevating your feet in the evening hours so you can start to redistribute the fluids and get rid of extra fluids before bedtime, not drinking close to bedtime. Those kinds of things can be done. Let's see here, hypertension. What medications are we on, right? If we're on a diuretic, well, that plays a role. Can be switched to a different class of medications. And that's where we work with the primary care doctor to determine, okay, is there a different class of medication that won't have a diuretic effect? Or some women who have issues where they need to have a diuretic on board, maybe take that diuretic not at taking in the morning, and then there are times when we'll recommend that she have another dose, perhaps like a mini dose at 4 or 5 p.m. in the evening, so that that diuretic effect can now work for her in the evening hours, right around dinner time. She takes all that extra fluid is released from the body, so it's not done at night, right? And so those are two things. Sleep apnea is another one, where women are not sleeping well deeply at night. They're waking up, and because they're now awake, they have to now go to the bathroom. Ordinarily, if they were sleeping deeply, they wouldn't have to wake up and go to the bathroom. And so if we take care of the sleep apnea, or any conditions, cardiopulmonary conditions that affect sleep, or sleep in just sleep in general. If we can get her sleep optimized, then she won't wake up. And if she's not waking up, she won't go to the bathroom. And if we can avoid going to the bathroom at night when it's dark, we can avoid a fall. We can avoid leaking at night, a slip and fall, all the things that can, and breaking a bone. These things kind of can cascade. So those are the things we talk about.
Yeah, yeah. Thank you so much for sharing that. And it's such a reminder that the whole body's connected, even, regardless of what specialty we're in or what we're doing, we're not taking care of an individual in silos. We're taking care of them as a whole person. And as an internist, I see a lot of patients with heart failure, hypertension, and yes, those lovely diuretics. And not even, just my female patients, my male patients also complain about these lovely diuretics that are so good for heart failure, pulmonary edema, and all this, but can also uncover or unmask other issues. So that is super super important. And I think the other one I was curious about is diabetics. A lot of people have diabetes,
Yeah, that's
they're
another
able
one.
to go through successful pregnancy.
Yeah.
Are there any special concerns that they may have or that you see commonly happen for women that have diabetes, especially if it's like suboptimally controlled? What are
Hmm.
some urological issues or urogyne issues that you may see?
Sure. So with diabetes, we know sugar is like that major toxin, right? So first of all, sugar pulls with it water. So the more sugar intake we have, the water kind of just goes with it. So a lot of people, women who drink overconsumption of sugary beverages and or food are going to be going to the bathroom more frequently because that's how sugar and water go hand in hand. So that's one thing. And then diabetes in itself is a disease that affects, when it's prolonged, can affect the nerve endings. And just like it can affect the nerve endings in the extremities, eyes, brain, it can affect the bladder as well. And so, yes, in women who have diabetes, they can have an overactivity of the bladder, urgency, because the brain controls the spinal cord and that sends nerve signals to the bladder. And it's a coordination. When the bladder's full, the brain gives the signal empty, squeeze and empty. When the bladder's not full, relax and hold it. But if the nerves are not working well, then that whole coordinated system doesn't work optimally, and the women feel a sudden urge to empty a bladder when the bladder is not full. And then even after she's gone, she still feels like she's full and has to go again. And so, yeah, diabetes can impact the way the nerves work and message each other.
Ah, okay. Thank you for explaining that. I think having other chronic medical conditions, in addition to pregnancy, can be quite challenging. And now,
Absolutely.
for the most relevant and most important part, talking about invasive procedures. So, say, the woman, that's just had a baby, everything is optimized. You've talked to her primary care doctor, they've adjusted her medications. She is diabetic, her A1C is back down to normal, and, she's still having a lot of issues with leakage. Perhaps she's noticing that the anatomy has changed.
Yeah.
She's done the Kegel exercises, and
Hmm.
it's just very frustrating. What are
Right.
some next steps you would suggest? What are some of the surgical procedures that may be done? Or I think I was alluding to it. I saw some commercials or big billboards about laser tightening devices. I'm very curious. What are your thoughts on all of this? What
Sure.
options should a woman explore?
Yeah. So, as I mentioned, of course, this woman has tried pelvic floor muscle exercises, maybe a pessary type device to help to support the bladder and or uterus if it happens to be there in the office. And if those things are not helpful, then if surgery is the next best step, then yes, as a reconstructive surgeon for 20 years, this is what I do week in, week out. And so we'll oftentimes start and look to see, can this surgery be performed vaginally? Right? Because we want to avoid major abdominal incisions for this elective procedure. So just like almost like a cosmetic procedure, we want to, minimize time away from work, pain, discomfort, bleeding, scarring, and all those things. So vaginal surgery is a very conducive procedure to meet those goals. And so, can this be performed vaginally? Can a woman's tissues be used for this repair? And so, there are repairs that can be done vaginally using a woman's natural tissue. So, a native tissue repair is what we call it, using suturing to support the bladder, to support the connective tissue, to strengthen the connective tissue and lift the bladder up. If it's a bladder drop, to help with the uterus, to re-support the uterus and leave the uterus in place if it's mild and not dropped too far. Also to support the walls of the rectum that sometimes can bulge into the vagina and cause constipation. We call that a rectocele. So all of that can be addressed vaginally using a woman's natural tissues, and that works well. Yeah, so that's typically what we like to do first to approach it. Works well, minimizes bleeding, blood loss, pain, scarring, quicker recovery, and yeah, we'll make a return to our usual activities within weeks once the sutures have dissolved.
Interesting. I've been away from OBGYN for too long. I was actually considering going in that direction as a
Oh,
medical.
really? I
Yeah,
didn't know
yeah.
that.
I did an elective in maternal fetal med, and then I did an extra couple of weeks even after the mandatory 6 weeks of OBGYN. And
Nice.
this was
Nice.
a while ago. And I think at that time mesh was in vogue. I think but now I'm in Canada, and I found that the trend for mesh in Canada lasted a bit longer than in the US. But you mentioned natural tissue. So maybe the first question I'm going to ask is natural tissues. I didn't have the opportunity to see the surgeries. I'm assuming these are a little bit newer, perhaps, or maybe not, that are using natural tissues. Where are these natural tissues coming from?
Oh,
Is it like from another part of the body, or is it like using the current tissues and tightening them up? Tell us a little bit more about these procedures.
exactly. It's using a woman's current tissues and tightening them up. And so the way I like to describe it to my patients, like, okay, you'll be asleep, you won't see, feel, or hear anything. We open up the vaginal skin or lining. And then underneath the vaginal lining is the connective tissue. That's the muscular portion that has muscles and all the structures. And then that's the area that we tighten up using suture material to kind of tuck things back into its normal place and strengthen them. Oftentimes, due to vaginal childbirth or aging, loss of collagen, chronic coughing, heavy lifting, chronic constipation, these the connective tissue can tear or weaken or stretch. And then what we see is a bulge or a prolapse, but the issue is underneath the vaginal skin. So once we repair these areas using suture material, then we can put the vaginal skin back together again, and that really resupports whether it's the bladder, the uterus, or the rectovaginal wall. And so yes, that can be done safely, successfully, and women do well with that. And to answer your other question, I was trying to remember was about the laser tightening devices. Those are devices that use either thermal energy, heat, or radio frequency energy to stimulate more collagen production to help to strengthen the pelvic floor. Now, the repairs are actually traditional, and those have been around for decades. The devices are more of what are kind of newer, so to speak. And those devices can help women when it's related to, for example, like menopause, perimenopause. There's less blood flow to the vaginal tissues. There's less sensitivity that women can feel that it can impact sexual function and intimacy. Then those devices, and there's less collagen production. So those devices can help to stimulate those things, similar to like micro needling of the skin on the face, and the wrinkles go away because things are so that can help. With prolapse, not really, not really the standard, so to speak. And so it can help in with some things, sexual function, intimacy, vaginal dryness, those devices, but not prolapse per se. And I've had some women see me who have had those devices and then come and see me because the prolapse is still there. So
Yeah, yeah. Okay, thank you for clarifying. Because it's like if you're not in the field, even for me as a physician, not in the field, I'm like, oh, lasers sound interesting. So it's very important to know the difference and to talk to somebody who's well versed and who, is a specialist in this area. So you're not necessarily investing in a procedure that is not accomplishing the goal that you
yeah,
really want to accomplish. And I
yeah,
want to backtrack a little bit. So going back to mesh, tell me,
yeah.
has completely, I know there was some controversy. Is mesh
Hmm.
completely gone? How do you, if it's still something that you guys use, how do you decide in between, say, using sutures, like a more like a lift procedure using sutures versus mesh is, or, maybe
Yeah.
kind of fill us in on what's going on with all of that?
Oh, absolutely. So as I mentioned before, in my practice and what I offer non-mesh options first. But if a woman's tissues aren't strong enough, for example, she's much, much older. I'm just going to paint a picture: 60s, 70s, not 40s, not 30s, 40s, 50s, but advanced age, where the tissues are no longer adequate enough, and I don't feel like we're going to get a good result, right, from the repair. Or some women may have had previous conditions, maybe pelvic cancer treatment, radiation. There are different things that the tissues are just not usable, or the prolapse is far gone. It's not like a mild stage 1 or stage 2. We're talking stage 3, where the prolapse is way outside the vagina, or all of it is hanging out. Stage 4, the last stage. Then that's just the tissues are telling us like, okay, I have no more tensile strength anymore. I have no more, to give. And then that's where we use mesh. Now, the issue with mesh is not so much the material as is, I like to say we don't throw the baby out with the bathwater. The mesh is useful. It's just that who is using it and who it's being placed in and how it's being done. So, when mesh is used by a experienced, board certified, fellowship trained, expert urogynecologist, in the best hands, who has the experience, the technique, the skill, then a woman's going to get the optimal outcome. So who is used handling it? Who is it being placed in? We're not placing mesh in 20 and 30-year-olds, right? Because the vast majority of times, a woman in that age group, her tissues are strong enough to use without mesh, right? Because when it's used in women who are so young, especially women who are going to have children, there could be issues with pain, and we don't want to introduce that. So that's the second one. And then the third thing is how is it being placed? Now, when mesh is placed through the vagina, like for example, if the vaginal walls are open and then mesh is placed transposed vaginally, that's where things can go wrong, because there's normal bacteria that live in the vagina. There's a whole vaginal microbiome, right? And so if there's a foreign body placed in that area, there's a higher likelihood that there could be an infection, and the area may not heal well, and then that can cause pain, scarring, bleeding. Not good. You're right. However, when mesh is placed, and in my practice, when I place mesh, it's placed robotically, laparoscopically. So in the ideal woman, where we can't use her tissue, she's much older, her prolapse is far gone, we want this to be once and done, then those women, I offer a robotic procedure, and it's called a sacrocolpopexy. It's a specialized procedure where mesh is placed through the abdomen, similar to a hernia repair. So we're taking this sterile, soft material that works well for repair, and placing it through the abdomen through tiny incisions, draping it over the vagina from the inside, and using that to lift the pelvic floor. So we don't have to cut or split open the vaginal walls from down below. We do it from the inside, similar to a hernia repair. And so then now we have this procedure that works well, that's placed well, and the success rates are like in the 90% range, give or take. And so that's where we can avoid the issues with mesh and not healing well vaginally, but still have the high success rates when it's done laparoscopically, robotically, because we're placing it through a sterile cavity, not through the vagina that has normal bacteria that live there. So that's how I approach women and who need mesh versus not.
Thank you for explaining. Yes, I saw the external mesh procedure and I was like, wow, this is quite extensive. But it's nice to hear now that they have them. You can do it robotically or
Mm-hmm.
laparoscopically. That's
Mm-hmm.
very, very interesting and very exciting to hear. And there's too many questions I want to ask you. I'm like, which direction do I go? So say we have a woman who has had, their first child, maybe they had twins, and then they had some issues, and eventually they underwent a bladder lift procedure
Yeah.
with sutures. Everything has gone well.
Mm-hmm.
Now they have a second pregnancy, and they're
Yeah.
worried that they're going to go through all of this again. Um,
Right.
and they're
Right.
considering their options. And they're considering C-sections. As I mentioned, I'm so far away from OBGYN, but I think probably things may have changed about elective C-sections may or may not have changed. But
Mm-hmm.
this woman is saying, I want a C-section. I don't want to go through all of this again. What would you tell her? Is this more risky? Should she undergo like a natural or vaginal delivery? What are some considerations?
So that's a very good question. So it depends. So we could start from, okay, so this woman just had twins. Did she have her twins by C-section or vaginal delivery? Right. So if a woman had her twins vaginally, chances are she just had two babies. There's probably some weakness already. If she's going to have more children, she hasn't completed her family. It depends. Why? Because, depending on the amount of time in between her babies, if she's going to wait 5 years, she may or may not want to wait 5 years and be uncomfortable and have the symptoms related to prolapse for 5 years, which I understand. And so some women may elect to have a vaginal repair, understanding that if she has another vaginal delivery, that may impact the durability of the repair, and she may or may not be okay with that. Or if she says, yeah, okay, I did have these two babies vaginally, but the next one I'm going to have a C-section, then of course, then that makes no difference. Let's go ahead and get you repaired. You're going to have your next one through C-section anyway, because that's what you choose to do, and that's fine. If she had her first babies by C-section and she's definitely going to have a repeat C-section, then of course there's no limitation. If you're interested in surgery, that can be done vaginally. If a woman's going to have more children vaginally, and it's going to be close together in time, then it makes sense to just wait after she's completed having her children. And I would advise her on that, because why repair this in a year or two, have a baby, and then so so those are the things to consider. Now, elective C-section, when I was training, 20 years ago, this was like, ooh, but it's not a big deal. I tell women, we give them pros and cons. Yeah, of course, having a having a safe vaginal delivery, uncomplicated vaginal delivery is easier to recover from, is associated with less risks compared to abdominal surgery, which a C-section is, right? But nowadays, women have planned C-sections. So when a surgery is performed under planned conditions, not in a hurry or rush or an emergency, then that can be reasonable as well. So women have choice; they have autonomy with their bodies. And so after understanding the risks and benefits of both vaginal delivery and C-section, then women choose what's best for them. And if a woman's planning a small family size, not and not planning multiple C-sections, it's not reasonable to have C-sections for your children and have that to be the first. But if a woman's going to have a large family, and there's no magic number, but that's where the counseling and the conversation comes. I wouldn't advise a woman plan to have 6 C-sections, so to speak. If she's going to have a large size family, so it's because that's associated with all the risks of C-section, scarring, pain, bleeding, all the things, major abdominal surgery, the risks, and with the baby, vaginal delivery, it's work for mom. The benefits for the baby, right? Passing through the birth canal, that helps to populate their microbiome, their GI flora, helps to with reduce risks of lung issues with the baby and breathing. So there are benefits to the baby for vaginal delivery, and women will find that they bounce back easier from a vaginal delivery compared to a C-section. So that, as you can see, there's so many factors to consider, benefits to mom and baby for either, and risks for mom and baby for either. And then after having a full conversation with the woman about that, that's when she can then make the decision as to which one fits her best.
Yes, and I can see why it's so important for somebody to go to an expert, somebody who really specializes in this field, is well versed and knows the future, potential complications coming down the line. Because I can see a lot of women thinking, okay, I had my first child, we're gonna have this procedure, I'm gonna have the second child vaginally, we're gonna have another third, fourth, fifth procedure, and maybe that's not ideal. But as physicians, there's a different thought process and mindset.
And I would say, not to interrupt you, I apologize, but in terms of pelvic floor, it now depends on what a woman's priorities are. So if a high priority is the pelvic floor, which it should be, but then there are also a lot of other priorities, baby health, recovery, and all the things, then yes, for sure, C-section does protect the woman's pelvic floor above and beyond vaginal delivery, generally, right? A planned C-section at least. And for women who are looking to avoid bladder leakage, and even more specifically, like bowel issues, fecal incontinence, for sure, there are benefits there with C-section. And in women who've had maybe a prior vaginal delivery, where there's been some trauma, I think you alluded to that before, where there's then oftentimes we will advise that next baby having a C-section. I've had women who come to me, they had a really significant 4th degree laceration with their first baby or so. They may have had an issue with fecal incontinence, bowel leakage. We fix that, or fistula, right? Because they had a repair during birth and there was a hole. And then we had to fix that. And we finally fixed that fistula. She's no longer leaking stool through the vagina, which of course we can only imagine how significant that is. The next baby, C-section, no questions asked.
Okay.
So,
Yeah.
yeah.
Yeah, thank you for breaking that down. There's definitely a lot of considerations.
Mm-hmm.
And again, you should make sure you're talking to somebody who's well versed, who understands the complications, understands the procedures, understands which procedures may not be right for you, and can, lay it all out. And speaking of procedures, I am super excited to hear about robotic surgery. It's been a
Yeah.
long time again. I think when I was a med student, robotic surgery was just coming out, and
Yeah.
I'm sure this is en vogue right now. I'm like, I have to formulate my question. So how would you decide? Maybe if you can do both procedures laparoscopically versus robotically, maybe break down what laparoscopic procedures mean, because some of our audience may not be in
Yeah.
the healthcare field. So how do you decide between robotic and laparoscopic? I think when I was a student, of course, things have changed. It
Mm-hmm.
was more about, if you're well versed or, very familiar with robotic procedures, some people could do them faster. There were less complications, depending. Some physicians who had not yet been doing robotic procedures were thinking it's more of a marketing kind of thing. I'm sure things have changed, but please fill us in on your thoughts about robotic versus laparoscopic. What are your favorites? What is coming down the pipeline?
Yeah. And so, yes, when robotic surgery, I introduced robotics into my practice in 2009, and it was newish then, but I think within it had been in the mid 2000s when it was being introduced, 2005, give or take, so to speak. And so there were a mixture of doctors then. There were doctors who've been doing procedures laparoscopically for years, and they said, why bring this tool that's more expensive, that's going to take longer, versus what I'm already doing. And so that was there was a mixture of outcomes then. And nowadays, yes, there are doctors who are well versed in laparoscopic surgery, and then doctors and surgeons like myself who are well versed in robotic surgery. So we can do a procedure just as quickly and maybe, and if not faster, robotically than laparoscopically. Ergonomically, it's much more comfortable for me to sit and focus on the patient versus that, plus be standing and hand-eye coordinate, and not just monitoring my motions, but also my assistant. And, so there's a lot more involved with laparoscopic surgery, whereas a robotic surgery simplifies it in my mind, where I can not just focus, the instruments are placed. I have an assistant by the bedside who's handing me needles and instruments, but then I can suture more intuitively without having to think about it, because I'm just using the natural motions of my hand as if I was doing it in an open procedure, so to speak. And so those of us now who've done, like myself, I've done over 1,000 robotic procedures, going on, 15 years now, we are pretty good. I'm pretty good at doing robotic surgery, but they're both minimally invasive options. There's some institutions that don't have a robot, right? And it is not a cheap tool. And so I would just say robotic and laparoscopic surgery are both minimally invasive approaches that have advantages above and beyond an open procedure: less blood loss, less scarring, quicker recovery, less risks post-operatively because of that. So that's kind of what I would say in terms of laparoscopic and robotic surgery.
Ah, awesome, 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 awesome. Yeah, it's very fascinating to see how medicine is evolving. And I think I have more questions. I'm gonna have to have you back, especially about laparoscopy versus robotic and the
Yeah.
future and open procedures and like, but this is more of like an, academic and the future of medicine. But that's
Yeah. Oh,
actually
yeah.
a
Yeah.
conversation for another
Yeah.
day.
Separate. Yeah. There's so many other considerations, socioeconomic considerations, and resource needy areas. And are they going to be able to afford so there's, of course, I mean, a lot of things to think about.
Yeah, yeah. But I mean, we live in very, very interesting times, super exciting times. Like the way things are advancing is extremely, extremely exciting. But with that in mind, thank you so much for taking the time
Thank
out of
you.
your schedule to come and talk with us and share your knowledge with us. And for individuals, I think I heard now you are in the Atlanta area.
Yes, I am. Yes.
Yes. So for individuals who are looking for a urogynecologist and they live in the Atlanta area, how can people find you? Are you serving or do you serve people who also live out of state?
Yes, I mean, I do serve people who live out of state. We have a lot of women who reach out to us either online or actually travel to Atlanta. They're in Atlanta for one of many reasons. So they schedule an appointment to see me. My website is drtugbiyele.com. So that's DR and my last name.com. I am the Urogyne doctor on all platforms: Instagram, Facebook, TikTok, LinkedIn. And those are the two ways to reach me. My office number, 770-292-4200. So those are the ways to reach me, and women can, either watch my YouTube videos and schedule an appointment. I'd love to be able to serve and help.
Awesome. Thank you so much. We will make sure to have all of your website, your social media handles, and your phone number linked at the bottom of the video so people can reach out to you. And thank you once again for being on our show. I'm going to have you back, and we are going
I
to
would
talk
love
about
to.
all things robotics and, things that are coming out in terms of technology when you're available.
Thank you, Dr. Anita. It's been such a pleasure being on your platform. Thank you so much for what you do. You really are serving your people so well. I'm so happy that we're colleagues and in similar professional circles. And what you're doing is remarkable, because a lot of women don't know where to go. And I'm so happy, and your people have a great resource in having you as their advocate. So thank you.
Thank you. To our audience, bye bye for now.
Take care. Thank you. Think back.